Next, Dr. Jorge Cortez will address the next questions in chronic myeloid leukemia.
Hello, my name is Jorge Cortez from the Georgia Cancer Center, and I'm happy to talk to you about the next questions. And for those of you who have long memories and are experienced on these, you may remember when we started these conferences, it was called Leukemia, the next question. So this is chronic myeloid leukemia, the next question. These are some of the questions that I think are important to address for the next few years in chronic myeloid leukemia, and based on some of the presentations that we heard at SOHO this year. What is the role of new drugs, and do we really need any more drugs? We heard about some molecular abnormalities that are present in patients at the time of diagnosis. What do we do with them? We continue hearing more about treatment-free remission, and we still need to address a few issues to make it more applicable to more patients. And then advanced phase, this is something that has lagged behind, and we heard some good information at SOHO. Where do we go next? Let's talk about the new drugs first, and the first question is, do we really need more drugs? And these are some elements where I think we could use improvement, particularly in the far right. We only have one drug that works against T315I. For third line therapy, we're very limited. Again, we only have ponatinib there. And then very important in second line after second generation TKI, yes, of course, we give them all the second generation TKIs, but that's not a good strategy. So we need more there. And we talked about something to eliminate the leukemic stem cell that can help us to a more effective treatment discontinuation, the advanced phase, et cetera. So these are the new drugs that are being developed. Cemeni, of course, is perhaps the most relevant because in a randomized trial showed improvement. And I think it may be very close to being approved by the regulatory authorities. There are others coming along the way. Radotinib is approved in other parts of the world, and then PF114, HQP1351, and KO706. These are all in ongoing phase 2 studies with some promising data. Well, I mentioned a Cemeni, but randomized trial very clearly shows benefit with a significant improvement in the rate of major molecular response at 24 weeks, the primary endpoint. Also very effective at T3 in patients with T315I. Please note that we use different doses in the two different indications. Now, there are some reports of arteriocclusive events in the assembled study, triple to what we saw with bosutinib, of course, with longer exposure as well, so that has to be considered, and some in the T315I. So with all of these, what is the role of asciminib? Certainly as third line, it looks very good, very high efficacy, not much toxicity. I do want to see a comparison with ponatinib. I do want to see longer follow-up and more dedicated investigation into the arteriocclusive events. I think that is very important. And the same thing can be said about the T315I. And for both of them, what is the right dose? Do we really know that? And historically, we've been very bad at doing the right dose in the initial studies with any of the given drugs. There have been attempts to add it on to improve the molecular responses. We could, there could be there's some good preclinical data, but we need clinical data here. Second line, we don't have any data. I think it'll be very important. Frontline as well. I think it has the potential there. Ponatinib looked great as frontline therapy, but the arteriocclusive events stopped the development there. I think there is potential there as long as the arteriocclusive event rate remains low. Other questions, I mentioned the dose, the incidence of arteriocclusive events, and the role of combinations. We have phase 1 data, but we don't know where to take these now. What about the other drugs? What is the role of the other drugs? Olverembatinib, which is the HQP drug, very effective particularly in T315I setting. I think that would be a good place to develop this drug, and that is where it's being particularly focused. It would be a nice addition, even if it is the third one in that setting. Vodobatinib doesn't work against T315I, but has worked very well in patients with or without prior exposure to ponatinib. So is that the role after another third line therapy? Possibly a second line after a second generation TKI. BF114, it's very similar structurally to ponatinib. I think it could be a good competitor as a third-line drug. Now, what about these additional molecular abnormalities? We have learned that a significant number of patients have other gene mutations that they occur in other cancers, particularly ASXL, and other Philadelphia-associated events that involve the cryptic fusions of ABL or the BCR or some others. And these abnormalities correlate with a worse outcome. There is greater probability of failure, and there is a lower probability of achieving the good responses, the deeper molecular responses. So what do we know about these abnormalities? Well, we know they're bad. The question is now what? The instinct is always, well, let's, if they're present at diagnosis, that's indication to use second generation TKI, third generation TKI, let's transplant everybody. But would these things work better? I mean, is this just a biologically different disease, and no matter what we throw at it, it'll be not the same? So we need prospective studies, and it is very possible that we need to use combinations, and perhaps combinations not with TKIs. There have been some attempts at using venetoclax and perhaps other modalities, immune therapies, etc. I think we need to investigate these better. But also, is this a cause or a consequence? Are these abnormalities part of the disease, part of what causes the bad outcome? Or are these consequences of just the genetic instability of the Philadelphia chromosome, and that is what causes these? Are they driving, or are they just passersby? So we need more biology studies in this regard. And the value, and this is important in the context of this genomic alliance that we are developing in the International CML Foundation that will help us understand these issues. Treatment-free remission, we've learned it's very feasible. Grossly, about 50% of patients who attempt treatment-free will remain treatment-free in the long term, although we are learning of some late relapses. But we also need to acknowledge that at best, half of patients will ever meet the criteria for treatment-free remission, which is what you see at the bottom of this slide. So if this is doable in 47% of patients are eligible, let's say 50%, and it's successful in at best 60% of the patients, this is successful in 28% of patients. So we've gone from you'll never stop therapy to the excitement of treatment-free remission, but now we have reached the ceiling of grossly only doable in a quarter of the patients. How do we improve these? That's the feature here. We can make the criteria less stringent so that more patients can stop. And that's what the Euroski has done. Instead of MR 4.5 for 2 years, they do MR4 for 1 year. And they say, look at this curve, it looks very good. Many patients remain in remission. Well, but look at what happens when you use more stringent criteria, MR 4.5 for 2 years. The results look much better with the STEAM, different studies. And of course, this could be just the problems of extrapolation. But it appears to be that we have better outcomes and a more stable plateau later on. So I don't think that that's the answer for making it more applicable for other patients. And furthermore, we know that with digital PCR, with those patients who are negative at digital PCR, meaning they have an even deeper molecular response, have a lower probability of relapsing. So clearly the answer is not to allow patients who have more detectable disease, but rather how do we get to less detectable disease? Now, part of the issue is we can wait longer. We have shown from the MD Anderson data that patients who have at least 6 years of duration have a lower probability of relapse. Something similar has been shown by our German colleagues. So waiting longer may be a way to make that probability of relapse go down. And now, how do we improve the success? More patients becoming eligible. There's been combinations. The combination with interferon hasn't really been that successful. We've done a study combining with ruxolitinib, hasn't been that successful. There's many other studies that are going on. I think that that's the way to go, but right now we don't know if or any of these combinations will have particular benefit. I'm biased for immunotherapy, but remains to be proven true. Finally, for advanced disease, we know that that this is bad. Look at what happens when you use dasatinib for accelerated phase after imatinib failure. Progression-free survival, overall survival is not really that great. And that's true for any of the second-generation TKIs. Blast phase, this is even worse. Even third-generation TKIs, if you use them as single agents, the outcome is not very good. You get some responses, but the progression-free survival and overall survival is not very good. We have shown that compared to transplant, the TKIs are better in terms of residual life expectancy if you do them in chronic phase. In accelerated phase, they're equivalent, but see that in 10 years, you only have 5 years of life expectancy left. And for blast phase, transplant is better, but it's still very poor. Some possible benefit comes from this combination of FLAG-IDA plus ponatinib from Mary Copeland and colleagues at the Hammersmith. And you see that this combination seems to be fairly promising. Obviously, the way to go is combinations, but we haven't really explored much. There has not been enough interest of developing drugs in advanced phase. No large systemic studies of combinations. We need to pay more attention. Sure, these stages are not as common, but these patients need help. We need focus on this part of the disease. So to conclude, I'll finish with this quote by John Kennedy. The greater our knowledge increases, the more our ignorance unfolds, and we are learning that we still have a lot to learn in chronic myeloid leukemia. So I'll stop here and I thank you for your attention.